thanks to all of your colleagues who've invited my colleagues, Cheryl Bushnell and Sabina Gazelle and I, to present to the LeaRRn Network. Today, we're going to be talking about the Comprehensive Post-Acute Stroke Services Study as a model for a learning health system. What is a learning health system? A learning health system, as defined by the Institute of Medicine report in 2012, is science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practices seamlessly embedded in the delivery process and new knowledge captured as an integral byproduct of the delivery experience. The key words here are continuous improvement, innovation, and best practices embedded in the delivery process. Learning health systems then, to meet these objectives, use health information technology and the health data infrastructure existing within the system. It applies scientific evidence at the point of clinical care, and it simultaneously collects insights from that care to promote innovation and optimal healthcare delivery. And most importantly, it fuels new scientific discovery, and I also might add new methods of clinical practice. What are the 4 required domains of a learning health system? First, it's science and informatics. We have to have real-time access to knowledge, and we need to have digital capture of the patient experience. The second domain is extremely important, patient-clinician partnerships. Engage, empower patients, families, and communities for transformative healthcare changes. Incentives to the health system align with their value propositions, not only for the health system, but for the patient and to the payer. And it has to be delivered with full transparency. And most importantly, of these 4 domains is the culture. Is the culture supportive of a continuous learning environment? Leadership has instilled the culture of learning, and they provide the supportive systems and competencies to achieve in real-time learning. So why learning health systems? Well, ideally, learning health systems enables rapid iterative learning in which evidence informs practice and practice informs evidence. As many of you know, I've spent a long career in randomized clinical trials and in pragmatic trials. And the truth of the matter, those randomized clinical trials, pragmatic trials provide evidence, but it takes years to develop the evidence, and maybe 15 to 17 years later, we can implement it in practice. That is way too long of a ramp up and learning curve to influence practice in today's environment of innovation, technology, and drastic needs for change in healthcare system delivery. So I'm going to share with you an example of a learning healthcare system and how we have transformed that into a research learning enterprise, and it continues to feed back to our healthcare system the ways to enhance practice for better outcomes of post-acute care for stroke. So why should we be concerned about post-acute care for stroke? We have revolutionized in the last 20 years, in the last 2 decades, we've revolutionized acute stroke care. We have rapid access to TPA. We have thrombectomy for large vessel occlusion. We've re-engineered healthcare systems to rapidly transport patients for the best hyperacute care. We've established the guidelines and quality metrics for that care. And we've transformed the survival of some stroke patients, as well as set quality indicators in place. However, the gap begins after discharge. We have transition to rehab, which could occur in multiple sites, and then transition to the community without integrated management of these patients beyond the acute episode. There's uncertainty in this structure of care about patient outcomes. We only know patient outcomes at discharge, and infrequently, we do know 90 days. We have unmeasured and often undetected social and functional determinants of health for recovery and secondary management, not known to the healthcare providers or appreciated by the patients and family. These unmeasured and undetected social and functional determinants of health really impair the patient and the family's ability to manage recovery and health for secondary prevention. Stroke patients are complex. They have chronic conditions. Stroke does not usually happen in a healthy brain. Patients who have stroke usually have major underlying comorbidities such as cardiovascular disease, diabetes, and over 80% have hypertension. Another important point is the interventions for recovery and prevention are multidimensional. It's not one TPA delivery or one thrombectomy, one removal of a clot, but it requires multiple domains intervention for us to be successful. But ultimately, as already outlined, this care, which is complex, driven by many factors of the patient's chronic comorbid conditions, social and functional determinants of health, is siloed in the healthcare systems, and the patients are ultimately dumped out of the acute healthcare system. I think one of our patients in the focus groups as we developed the comprehensive post-acute care strategy said it best. I was life-flighted in and parachuted out of the acute care system with a hole in the parachute. And then let us hear a specific patient voice. This was a gentleman, 60 years old, who lived in the community, was on the board of the healthcare system, an accountant. And he says, after the stroke, I had new prescriptions. I couldn't dispense my medications into daily doses. This math deficit was not recognized until I got home. I lived alone and I had to take care of myself and I was unable to cope. A follow-up phone call has got to be a prime piece that has to happen in the stroke recovery process. But the caregivers are also perplexed and need many resources. This is a quote from a very informed member of the American Heart Association after her husband had a stroke. As a caregiver, it is overwhelming to come home and suddenly be faced with not only new medications, but an entirely new way of life. Even for someone in the know, it's scary. We must offer timely follow-up and connections with the community. They are game changers. And then what does the data say? In the COMPASS study we did in our first 3,000 patients, 2,595 to be exact, with mild stroke and TIA survivors, we assess residual social and functional determinants of health. But these patients in this particular study are extremely mild TIA survivors with a median index, National Institute of Health stroke score of 1. 75% were hypertensive, 70% were on 5 medications, 36% had cognitive deficits that had been undetected, 18% were depressed, and 48% of the patients, after they left the hospital, did not recognize or embrace hypertension as a risk factor for stroke. And within 7 to 14 days, 20% were medication non-persistent. The caregiver needs, in a sample of individuals with these mild strokes or TIAs, 1/3 of the caregivers provided over 30 hours of care per week, assisting with at least 1 activity of daily living and 6 instrumental activities of daily living. And the average standard caregiver strain was 21.9. And women caregivers reported the highest strain. So realizing the complexity of these patients, our colleague, Dr. Cheryl Bushnell, well over 10 years ago, developed in our health system at Wake Forest Baptist Health a program called Transition Coaching for Stroke. It was developed not as a research enterprise, but part of the neuroscience service line, and as part of the comprehensive stroke service. She developed a quality improvement initiative to improve transitional care for stroke patients discharged directly home. She set up a team of a nurse practitioner-led transitional stroke clinic to follow the patients after discharge, and there was a registered nurse to provide a comprehensive assessment. It was done, again, to remind you, not as a research project, but as a quality improvement project within the context of our comprehensive stroke center. It is a model of a learning health system initiative. We evaluated the outcomes, reported these outcomes in Stroke Journal in 2016, over 5 years ago, and we demonstrated within our health system with this enterprise of transitional care, we reported that we could reduce hospital readmissions 48%. And we found that multiple chronic conditions and previous stroke ischemic attacks are they're at increased risk, as we found and reported in this article. But the big questions, in order to impact healthcare, are the results sustainable or scalable? So we as an academic comprehensive stroke center started as a learning health system and quality improvement, set the practice, evaluated the outcomes, but we knew that we had to evaluate it with a broader population. And so we developed a PCORI grant, and we were ultimately funded in 2015, a $14 million pragmatic trial to see if we worked across the state of North Carolina with over 40 health systems, 20 in the intervention arm, 20 in the control, if we could implement this model of care and we would evaluate the outcomes. Wake Forest, again, as a learning health system, always served as a vanguard site for all of our initiatives in this research program. We vetted and tested all of our methods and processes and educational models within our learning health system. And we also have subsequently developed an EPIC stroke registry and electronic care plans integrated into our medical records. So again, all keyed by an academic health systems, learning health system approach. So let me tell you a little bit more about the COMPASS trial. It has come to end this year. It was a cluster randomized pragmatic trials. 40 hospitals were randomized in North Carolina, 40 hospital units. In phase 1, we enrolled over 5,882 patients, and we've subsequently enrolled in phase 2 about 4,000 more, but I'm going to be talking to you about the phase 1 results. Transitional care was implemented in the clinical workflow, and we also did it consistent with CMS policies and reimbursement. And our primary outcome for phase 1 was, did the patient improve their functional status as measured by the stroke impact scale? The model expanded on the TRACS model in that we called the patients at 2 days, which the TRACS model did as well, had a clinic visit within 14 days, and did follow-up calls at 30 and 60 days. What was different about this model versus a TRAC is we used a digital tool to assess functional and social determinants of health, immediately generated a care plan, individualized those care plans for secondary prevention, rehabilitation recovery, caregiver support, and most importantly, we linked them to available community resources to help support their recovery and secondary prevention in the community. And it's really important to note that we learned from our stakeholder engagements that we needed everybody to sing from the same hymnal, as we say in the South, that the nurses, the doctors, the caregivers, the social workers, everyone really spoke the same language. So we developed this messaging that in order to recover or manage your secondary prevention, you need to have a compass. And that compass, the north of that is know your numbers, know your blood pressure, your blood sugar, your cholesterol. E, engage, be active, engage in your mind and body support, be physically active. Support, ask for support when you need it. And willingness, are you willing to manage your medicine and lifestyles? And this was developed with focus groups of clinicians as well as patients and caregivers. And we engage patients, families, and communities, right? So we empowered the communities to come together by reaching out to them at every health system that was involved in the intervention phase. And as you see here, we empowered patients as we developed the intervention. They provided us feedback, and we had a patient stakeholder in our steering operating committee that guided us. So that was the most important pillar of the domains of a learning health system. We use science and informatics, real-time access to knowledge, and digital capture the patient experience. We developed the COMPASS CP program, which we call now, where we interviewed patients in real time and immediately generated a care plan, and were able to get it back to the electronic medical record so that all providers would see the care plan with the patient and embrace it as they manage them. This electronic generated e-care plan, as I said already, is linked to community-based resources. And there are a lot of resources in the community that patients often aren't aware of. Obviously, we all know stroke support groups, but there are falls prevention programs. There are health system as well as Department of Health programs to help manage your blood pressure. So we selected targeted and community resources and linked the patients and their caregivers to those. But it was all done electronically in real time. And once you interview the patient, it's as quick as a click, and you can generate this plan and link them. The other thing, incentives. Well, this is a noble effort, but you have to have incentives for health systems to be able to participate in this. Well, the first thing is that incentive, well, do you get paid for it? Well, CMS has established priorities and reimbursements for transitional care for complex patients like stroke and TIA, and those have been established for well over 4 years. And so there was a mechanism to be reimbursed for that if you were a Medicare fee-for-service patient. There were also hospital readmission penalties that as we started planning for this trial, as Dr. Bushnell developed the TRACS programs, health systems were brought in 2011 into penalties for readmissions, high readmissions. Stroke was not one of them, but congestive heart failure, pneumonia were 2 prime examples. We also have value-based payment models where that should be an incentive that now that is accelerating compared to when we started this trial, that the health systems, if they accept the patients in acute care, they will be expected to manage their outcomes for the long term and have a bolus of money that they have to distribute. And of course, bundled payments is part of a value-based payment model. So let's go back. We established this with those 4 domains, building on the experience of learning healthcare systems. And who were our patients that we enrolled in phase 1 of this study? Their mean age was 68 for the intervention. Usual care was 66. We had, it's very important to note that we had a large proportion of minorities, 20% in the intervention group, 32% in the usual care. And as I've already mentioned, most were mild strokes, but we had well over 1/3 of the patients were TIA strokes, and we had NH stroke scale scores. We analyzed this study with good methodology, and a primary analysis was intention to treat. We compared intervention versus usual care using a linear logistic regression with random effect for hospitals. So whether you got the intervention or not, if you were in the cohort of hospitals that were control or intervention, regardless of whether you got the intervention, it was an intention to treat analysis as we looked at outcomes. We adjusted for age, race, sex, stroke severity, and diagnosis, and we used inverse probability analysis. In addition to that, intention to treat, we also did what we call a post-hoc within hospital treatment effect. And in this analysis, we looked at intervention hospitals who provided the care, and we looked at the patients who got the care within the intervention hospitals versus those who did not, adjusting for a potential confounding. So let's look at the results. What we found in this pragmatic trial, in which we did not provide additional financial resources to deliver the intervention, within the intervention hospitals, only 35% of the patients received the intervention. The biggest barriers were system level barriers, consistent staffing, competing priorities. During this particular trial rollout, thrombectomy became just the really big a ticket item for interventions, and they shifted in some cases to really focusing their team on thrombectomy and removing resources for post-acute follow-up. And they didn't always enroll or schedule the patients prior to acute care discharge. And most importantly, only 48% of the hospitals delivered the intervention uninterrupted. And in fact, many health systems treated it as a PRN clinic. If the nurse or nurse practitioner were going to go out on maternity leave or a medical event, well, we'll close the clinic till they come back. We don't do that for acute care, and we don't do it for ED care. What were, though, the characteristics of successful sites? There were sites who were highly successful. The biggest factor was there was a commitment, a champion for the model of transitional care and acute care. They shared the vision that they were responsible for the patients beyond the acute care episode. The system dedicated resources to implement it. They were very flexible and collaborative. In any learning health system enterprise, you learn as you go. And as you learn, you need to be quick to adapt. And we tried to create this in this model, and some systems embraced it. The successful systems did. We also found that if the practice was related to a neurology clinic, they were more successful than trying to diffuse it into primary care. And most importantly, there was an embracement that this is going to be a new standard of care, and we better learn as a learning health system with this team how to use it. Those were the characteristics of the highly successful sites. So what were our results? In the intention to treat analysis, remember, only 35% of the patients got the intervention, but we still had to count they got the intervention in our analysis compared to usual care. There basically was no difference in the stroke impact scale or the functional status. There was about a 1.1 difference, but it was not statistically significant. And that was true for all of our secondary outcome measures, except for one. And you're going to see this as a theme throughout, blood pressure monitoring. In our analysis, what we found is that there was a significant effect on patients who did self-report that they were now monitoring their blood pressure more closely, but the other outcomes were not significant. We also looked in a subsequent analysis that we just completed at 30-day, 90-day, and 1-year readmissions. And again, in brief, there was no difference between the intervention and usual care in controlling 30-day readmissions. 90-day was our primary outcome, and when we followed them to 1 year, and no difference in mortality. It is important to note, though, if you look in the aggregate at readmissions and mortality, what you find is that these patients at 1 year are very likely, over 46% are going to be readmitted at some point in time. I'm not displaying the ED visits, but 50+% had multiple ED visits, and collectively we had 8.5 and 8. So they still are high utilizers, they still have needs, but in a pragmatic world, which we were looking at, the real world uptake, can health systems deliver this to influence the outcome? There was not a significant effect. However, when we looked at our post hoc analysis and looked at patients who got the intervention within the intervention hospitals versus those who did not, and remember I told you some hospitals started the clinic, they closed it for a while, started back again, or some started it and didn't continue it. So we had the opportunity to evaluate this in post hoc analysis. And in this analysis, guess what? We found those patients who got the intervention improved their functional status, they had improved satisfaction, again, better blood pressure monitoring, and there was a significant effect on survival to 90 days, and they were less depressed, and they didn't change their physical activity necessarily, but they did have less disability. So what are our primary conclusions from this model that was scaled across the state of North Carolina in phase 1 to over almost 6,000 patients? CMS established the priorities. There was a payment incentive. But this model of care was not easily incorporated into the systems of care, and there was no significant effect on any of the outcomes except blood pressure monitoring. There were consistent findings of improved blood pressure monitoring, both in the ITT and post hoc analysis. So, conclusion from the claims analysis, similar to the functional status, is that no difference in those readmission outcomes, emergency room visits, and mortality. However, we did change the process of care. We increased TC billing, we increased the ambulatory care visits and management of advanced care providers, and that was the intent of this model of care, albeit the TCM billing was still very low, less than 30%. So we changed the process of care, we did not change the outcomes. We've also looked at the research with our colleagues at Chapel Hill, North Carolina, Justin Trogdon and Bill Bayless, and we've looked at, well, what does it cost to implement this system? Because cost drives healthcare systems decision-making. COMPASS did exhibit a positive economies of scale. The average per patient costs were lower among larger hospitals. The larger hospitals, the less it costs you to provide the intervention. And they also demonstrated that if you could, COMPASS could lower the net cost if the model is able to prevent about 6 readmissions per hospital per year. That's an absolute number to treat, not very many if you can provide the intervention. Dr. Gazelle will speak about this in a few moments in the discussion, but she has been a pioneer in leading our implementation analysis, which was not funded by PCORA, but was funded by Wake Forest CTSA. And some of our qualitative findings, just to highlight, and she will speak more about this later, was are systems ready? Anytime you are going to implement something as a pure within system learning health system approach or a broader research approach, the first question you ask, is there organizational readiness? Is there commitment to your model of change? Is there a capacity, staffing, resources to do it? Is there confidence the team can manage the politics? Those of you who know me know I'm really good at science. I say that science is my passion and politics is my handicap. Don't laugh, I could see you laughing. But you really have to be able to manage the politics and competing priorities, and you have to have demonstrated efficacy to bring about change. So sites that were organizationally ready were more quickly to initiate the implementation, address challenges, redesign workflow, and they were great partners. They could leverage existing relationships. Adoption, the staffing was critical. We had to have staffing that embraced this, as you will hear in a video in a moment, one of our most successful site, a premier, it doesn't have to be the physician always, it can be a nurse on the front lines or the nurse practitioner. They have to be able to own this program and they're going to make it work. Ownership is key. So again, many other qualitative findings that we found, and really importantly, and also why we think, we do not know, but why we think blood pressure was demonstrated to be beneficial, is that you need to meet the patient's pre-discharge whenever possible. Get to know that patient, be able to be ready to engage them as they transition into post-acute care. Make sure that your time of follow-ups are timely within 2 days, and be able to anticipate issues with billing and be able to link to community resources. We also think that the blood pressure was so profound because we started messaging on blood pressure. We didn't wait to the 2-day call or 14-day visit. We messaged prior to discharge, and we actually gave patients in some of the health systems blood pressure monitoring devices. But the big ticket is this: health system ready to change. The fourth domain is the most critical one for learning health systems. You must be able to you must engage systems that have a continuous learning culture, leadership that are willing to support the effort. The COMPASS trial provided a realistic measure of TC uptake and its impact for stroke as delivered in real-world practice in diverse health systems. And our conclusion is that the culture, the resources, the staffing to implement this model is not readily available. Most clinical practitioners are not prepared to modify their systems of care to accommodate comprehensive post-acute management in the current healthcare environment. But some systems were, and I'll just give you an example of an incredible health system that is continuing to expand and build on this within their current enterprise is New Hanover Health System in Wilmington, North Carolina. Their PAC for their health system was able to connect patient to senior services to reduce their cost of the health system from $400 to dollars, what it was originally costing them, to $38. That's a huge health savings. And then LeaRRn, we had an incredible nurse leader partnered with a paramedic in the community, great physician leadership, and they built a seamless bridge. They thought outside the box. As they implemented it, they used the community paramedic system to follow up their patients, and they are now using this model with other chronic health systems, And what I would like to do is let you hear their perspective. So the take-home message that I'd like to leave with you is one from Peter Drucker many years ago. Culture eats strategy for breakfast. Learning health systems begin with the culture, and culture change is hard, but we will not give up. Wake Forest Baptist Health is continuing on this journey as a learning health system. We learned not only from our TRACS program, we've learned from this a large pragmatic trial. We are the Vanguard site, and as a Vanguard site, we're continuing to modify and learn. We are going to continue to embrace this in our service line and our neurology department. And we have integrated the electronic capture of patient-reported outcomes within our electronic medical record, which has been no small feat of innovation, and we're going to scale it. And we're also looking at how do we change the system. As I've mentioned, we've integrated into our health medical record using FireSmart technology supported by our IT team here at Wake and an incredible bioinformatist, Dr. Amit Topoglu. We also think that tracking patients through the hospital stay is critical and most expensive per the cost analysis. So we are looking at how to streamline that, maybe to interview the patients at the 2-day call and have the care plan ready when they see their nurse practitioner or primary care neurologist in follow-up. We know that this has, and we continue to improve our clinical workflow for implementation. And what we've learned is that patients are really overwhelmed. And so we are now prioritizing blood pressure management because if you manage blood pressure, guess what? You've got to manage medications, you've got to manage your diet, and you've got to be physically active. And physical activity really drives recovery. And we're looking at, and we are implementing it in a tele-rehab model. And we've taken this in our learning health system, are continuing to refine it in our current model of care. And we are under pending review for subsequent funding from PCORI to focus on blood pressure management using a more integrated model, also using wearables and real-time monitoring of blood pressure. So it's a learning journey, whether it's research or learning health system, but Wake Forest Baptist Health is incorporating this into our health system. It is not more known that it's hard sometimes to get new partners to embrace this. We have a new partner, Atrium Health, and they're not ready to embrace it yet, but there will be one day. Pam Duncan's here, Cheryl Bushnell's here. They will embrace it, but you can't change a culture immediately, especially in the middle of a major merger. And not only that, it's all about innovation today. And everybody thinks if you slap a physical activity monitor on someone or give them a scale or you do a blood pressure monitor, you've got the solution. Well, no, those of us on the front lines of healthcare know that it's more complicated than that. However, those of us on the front lines of healthcare do have new integrated platforms to monitor in real time and then inform our coaching and inform where we're going. And so this is the schematic of our efforts to bring technology to a different level to help us manage these patients and to use machine learning. And let's just take blood pressure as an example. Your blood pressure varies in a day, right? But we hope it stays within a range of function. And so, yes, you can't take one measure of blood pressure at one point in time and say, oh, you're really hypertensive. Well, maybe you were running a marathon. Whatever you're doing, we need to be able to have more continuous monitoring and develop machine learning and analytics to know when the blood pressure is really out of control. Pam Duncan Direct says that our current medical model, oh, go see your doctor. You know, how many of you get your blood pressure measured right when you go to see the doctor? But even when you do, it's a one point in time. And what's the easiest way to solve it? Adjust the medications. It's not just about adjusting medications, it's adjusting lifestyle, embracing that blood pressure is a cause of major cardiovascular disease and stroke, and working with the patient. Our journey in a learning health system is no longer about the quick technology or even the quick fix for potential bad outcomes while life flighting patients in. Extremely critical, but that life flighting patients in, giving them TPA does not affect their risk of future stroke. So what we want to be able to do is continue to learn as a learning health system, implement it in our practice, hopefully engage our fellow colleagues at Atrium one day to embrace this as well. And then hopefully the PCORI next funding may come through. We have developed numerous resources. This website is temporarily down, but will be available back and live soon. That's in public access that any of you can use these resources. But life is a journey, and I am privileged in my life to work with this incredible multidisciplinary team. It's taken a shared vision, respectful of diversity, accountability, committed to patient and community engagement, perseverance, and innovation. And I would also say, really committed to dealing with the tremendous health inequities, and problems in healthcare of access. We are here to really move that beyond, because African Americans have the highest risk of blood pressure, and North Carolina's in the stroke belt. So we will continue, and it's a learning journey. Here's an article by our colleague, Matt Reeves, who puts this COMPASS trial in perspective. Here's the publications, and now I will entertain any questions. Thank you very much.